Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm excited to be talking to Dr. Til Jolly. He's the Chief Medical Officer for SOC Telemed, or Specialists on Call. He's an emergency room physician, and he's also worked on the medical staff for the league for a number of the Super Bowls, up to number 46, I believe, and has also been a federal employee working with the Department of Homeland Security and FEMA on a number of projects. Dr. Jolly, Til, thanks for joining me today.
Good to be here. Thank you.
So if I may, what I'd like to do is just start out with a little bit about Specialists on Call and the telemedicine world. One of the things that I think I've certainly seen over the course of many years is it's just been sitting on the sidelines waiting, ready to happen, but we just haven't quite gotten there. What's been your experience, and how is the sort of implementation and the experience going with SOC Telemed?
Well, thank you. Telemedicine as a method of delivering care is actually quite old and established. Doctors have been helping to manage patients remotely by phone and sometimes by video for quite a long time. But really, the future of it, this current state and the future, is really in growth and standardizing how telemedicine is applied at scale across the system, with the goals of improving quality and improving access and improving cost. And all those things are very important. What we do is specifically provide specialty telemedicine services to acute care hospitals, and also increasingly providing our platform to hospitals to use for their services. Because it's one thing to put a physician in front of a patient, but all the things that go into that, operationally, organizationally, logistically, legally, financially, are difficult, and that's what our organization really specializes in. We do neurology, we do psychiatry, critical care, 36 states, about 450 hospitals, and growing very rapidly for hospitals that need those services.
So as you think about that and the sort of history and the challenge, and I agree with you. I mean, even in my era of many years ago, the telephone was a key asset that we had prior to home visits. It would actually stop you from having to go and see physically a patient based on a conversation. But it's never felt like we reached tipping point, to use the term that Malcolm Gladwell defined and wrote a book about. Any thoughts about why that was? What's prevented telemedicine from really taking off and just exploding onto the scene? Or maybe it has.
Well, I don't know that there is a specific tipping point in this, but we look for various tipping points. There are a number of factors that make this, to use your term, an incremental process to achieve success. We are seeing a boom in the use of telemedicine by many organizations, both for things similar to what we do in acute care hospital space and also in the outpatient space. Some organizations have as many as 50% of their visits done by telemedicine in the primary care space, for instance. There are a number of potential barriers and reasons why it's not universally adopted. Technology is not really a barrier anymore. Technology has gotten so easy and cheap. It was a barrier, but it's gotten so easy and cheap that as long as there's some kind of access, although we have to remember that much of our population in the U.S. Still has difficulty with access to the internet. So that's not a universal resource for everybody. But putting that aside for a second, acceptance by hospitals and healthcare providers is still lacking in some areas. There are still many that we go to from a sales standpoint, or just interactions in professional organizations, who say, yeah, that all sounds really good, but I want somebody there, even when the somebody there probably isn't going to provide anything more than what a remote provider would. Now, there's certain things you obviously can't do remotely that are very manual and physical, but the array of things you can do remotely is quite wide. And then, in every situation, one has to talk about the money. And reimbursement for telemedicine is still a bit of a problem because it is variable state to state. There's the Chronic Act recently through Congress will probably make some difference, and Congress is coming very far toward including telemedicine, at least for Medicare reimbursement, and commercial carriers may follow that. And then hospital administrators have to then begin to understand that and put that into financial models to make the system work.
So it's interesting, you bring up a number of elements there, so not least of all the reimbursement, and one of the things that certainly seems to me as something of an outsider here, although I live and work here and have done for many years, is this challenge of cross-state provision, and then the technology piece, which, in your mind, albeit it's imperfect, but for the most part, we can fix that. As you look back over the course of time, what were the small things that changed that, you came in one day and thought, wow, we've stepped up to the next level based on the experiences of, new innovations, perhaps FaceTime, for instance. I would say that I did telehealth with my mother for years on FaceTime. Mm-hmm. Any thoughts about some of the changes that have occurred over the course of time that have stepped you towards that goal?
I think there's some very simple things, as is true in lots of change. I can recall a story of one of my mentors who is quite an innovator and quite a thinker, and in emergency medicine. And one of our colleagues once told me the story of the time he convinced my mentor to put a fax machine in the emergency department and to invest in that. And what that allowed us to do is to transmit EKGs, about old EKGs, on patients and really improve care. And it strikes us as kind of silly now, but being able to accept that technology really changed the way I could practice with a patient at the bedside. And then, technology like FaceTime and simple video, they're now, you can do video in any sorts of ways now. And the electronic health record has been, for all of what's the electronic health record is a discussion for another day, but the ability to exchange information and to standardize that really has made a huge difference. And then just, as with many changes, just society's acceptance of these technologies and these methods as a way of communicating. Our kids, our kids now do their homework by video with their friends, and it's not even really a question anymore. And really, the medical community is very tradition bound in many ways, and hopefully becoming more innovative in other ways. What's going to be really the driver, I think, of a lot of change is the increasing push to apply science and true quality measures to what we do as telemedicine providers through efforts at the national level, the National Quality Forum, trying to apply research metrics to this, an organization called CHQI, trying to attach accreditation methods to organizations to really increase some standards, and allowing then medical boards to have some confidence in what's going on.
So I agree with you, and the fax machine just I smile a lot because I remember the first time I introduced a fax into our family. I actually gave my father one because I was living overseas, and we used to write letters, and I said, wow, there's this really cool technology. We could fax letters, and he was outraged. Having this device in his house was just, he was ready to kick it out, literally. But interestingly, as you've clearly had that experience of, wow, suddenly this instant sort of form of communication really sort of delivered some value, and people adopted it relatively quickly. As you think about the pushback, what's been the major sort of pushback from clinicians or even patients? What are they sort of saying about this whole experience?
It's in our experience, we see about 65,000 patients a year around the country, which is, there are Many of our colleagues in the industry who are in the direct-to-consumer part of the industry, where you can pick up a phone and get hooked up to a doctor for essentially an urgent care visit, it's a different model. They see more patients than we do, but we see sicker patients than they do. So it's a similar workload. In general, in our experience, the patients are not particularly resistant to the idea at all. They even those who are not tech savvy, because of neurology, we see a lot of patients who are older and sometimes of lesser sophistication technologically. But the idea that they can get something that they believe they could not get otherwise gets them past that pretty quickly. They will engage in social interactions with our providers and ask them, where do you live? Where do you live? Where are you right now? And it's very interesting to hear some of this. And even our psychiatry patients, we have a pretty heavy psychiatry and behavioral health cohort, and it's growing for all sorts of societal reasons. And that population actually sometimes finds it better than having a provider live in the room, because there is no human there to feel threatening or intimidated, or and it allows them to be kind of detached. There's no paranoia about the screen. It's really a comfortable environment. The resistance is still in the providers who are very traditional, or the hospitals who are very traditional, or it's a little hard to express sometimes, but physicians and hospitals like things done in a certain way. And many times what they will try to do is to take the technology and figure out how to do what they do the way they do it with that technology. When in fact, if they would step back, they would see, let's rethink how we do the entire process using that technology and using that technique, and then they'll get it, but it takes quite a while to get there.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Til Jolly, the Chief Medical Officer for Specialists on Call, Telemed. I couldn't agree with you more. In fact, it relates back to that conversation and your point about the EHR. What we did was we took the paper process and then automated it, and doing the same with telemedicine doesn't make sense. I love the concept that for some patients it's better. I mean, that's actually I understand that we need human contact, but sometimes it's easier just to do this through a piece of technology. One of the interesting things about AI agents is that people are more honest to them because it's not a real person, even though that information ends up in a real person. As you think about the future, where's this going? Are we getting to the point of sort of this remote interaction where there's even more physical potential, or not physical, I mean sort of examination or tool sets that can be delivered? Do you see us going to more capabilities in this space?
I think we will go to more capabilities. I think we will improve. We will certainly grow just in pure numbers, but then we will probably learn much better how to do things in a better manner rather than just attaching a piece of technology to an old technique. And I think one of the really interesting innovations will be moving from a very episodic, almost transactional relationship with patients, providers on the far end, to a more ongoing management and interactive and supportive model. We are already working on that and thinking about that. That's applicable to the outpatient space. It's applicable to the inpatient space. It's applicable, why there are 15,000 skilled nursing facilities in the country, or some number such as that. The value in those facilities for ongoing care and reducing readmission is we've really just scratched the surface of. And so incorporating that into the assumptions of how the healthcare system should work is really the next step. Now, telemedicine is not the answer for every problem, but what it will be, I believe, is increasingly used as an accepted tool and something that a system really can't do without.
Yeah, and I think a big enabler of one of the highly desirable outcomes in healthcare, which is aging in your own home. circumstance versus having to go into a facility. If we can apply that technology to help support that, I think that's certainly in my personal experience, that was what the elderly population tended to prefer and desire.
And you know, yeah, there's certain things you can't do in your home, but there's a lot of things. There's monitoring and health improvement, and simply just having a professional look at the home environment, patient aside, roaming around looking for throw rugs and things like that, can really make a huge difference. Or looking in somebody's refrigerator and seeing what's in there, or something. There's all sorts of applications for that seem kind of silly, but really are a way of improving someone's life. And then, you know, there are discussions about loneliness among this population, and it's not direct touching human interaction, but that is an element for a lot of the aging population, and really showing them how easy this is. And instead of having to get in a car, get in a cab, or get in an ambulance, or getting something to go to a doctor, which is really a pain, having more frequent visits from a provider can probably have those side effects that aren't even really the intended side effect.
Yeah, I don't know if this is culturally going to resonate with people, but I used to, my mother did something called Meals on Wheels, which was a service to the elderly population. I used to go around with her, and it was interesting. Many of those patients, the only contact they had was the 2 times a week that we would visit with anybody actually coming in, and providing something in addition to that, I think, is so important. It's going to be a key piece of our future. So exciting. I've got to ask, because it continues to sort of just puzzle me. Are we going to remove the state line issue for practicing for healthcare? Stick a stake in the ground, can you?
We get asked that a lot. We deal with that a lot. The current rule is that in order for telemedicine to be practiced, the provider needs to have a license in the place where the patient is, not necessarily where the provider is. And, there's no particular technical barrier to getting a signal across the state line. And so that rule was considered long ago, and various advocacy organizations pushed for rules otherwise and were not successful. So that's the rule now. And so there are efforts to try to get around that. There's a state licensing compact that has been approved by a number of states, but a limited number, and there are certain states that have pretty closely said they're not going to do it. So by that compact, once you qualify for one state license, as long as you pay your fee, you can qualify for another state license without the huge background process. That's a good thing. State medical boards are very serious about their autonomy and their right to protect the citizens and inhabitants of their state, and are very independent. So the idea of national medical licensing, maybe in the future sometime, but it's pretty far off.
Okay, fair enough. So we got a little bit of time left, and I know I'm certainly curious. You have this fascinating background with some experiences with the NFL. Can you tell us a little bit about what you did and what that was all about?
Yes, it was one of those things that I professionally didn't really aim at, but ended up in because of some colleagues that I knew, and they still do it. It reached a time when I couldn't do it anymore from a time commitment. But there's a group of providers, including physicians and a firefighter and a paramedic, who are all experts in emergency management, emergency medicine, emergency procedures, event planning. And they have worked for years with the National Football League as the medical liaison and staff for the league when this league goes into a city for a Super Bowl. And the teams have their own doctors, and you're not going to get in between the doctors and their teams. But there still has yet to be a team that has the game in its home city. So you have 2 teams coming in from outside who need resources and who need in a very high profile event. Plus there are thousands of staff who come in well in advance of the game. People have no idea what goes into preparing for this. It's weeks and months of preparation to get this ready. That staff needs to be managed and taken care of. And then there are all sorts of ancillary events besides the game. And some communities have hosted these games a number of times, some haven't. And the scale of it and dealing with all of the various entities can be very difficult. So we worked with local hospitals, fire department, EMS, police, and others to manage the routine day-to-day medical needs, the teams, the fans, the staff, and also to work with them on contingency planning for any emergency that might occur, whether it be a natural or man-made emergency. And unfortunately, in this day and age, you have to plan for that sort of thing. But it's very important. And we brought to the local officials a knowledge of what the NFL did and how that event worked in other cities. And then during the game, we each had a specific role related to the management of the game, which was largely a liaison role between local providers who are now having the biggest event in the country in their city at that moment. And with everything else going on in their city they have to deal with, which is a normal, and the league, which is an entity that normally is not in that city. So it was a fascinating event. It's got the medical part of it is really very small. We thought it was very important, but it's very small. But it's a fascinating organization to watch how that is all carried out.
So as you think back to those experiences, any sort of small learning opportunities, something that you didn't know before, but as a result of that exposure to those events and some of the backdrop that stands out that you could share?
Well, I think you learn when you're in the sort of the emergency preparedness and the emergency planning events business, either in government or in the private sector or where they intersect, that you really need to carry the lessons from prior events into the new ones and not learn a bunch of new lessons. Communications are very important. Clear understanding of roles and responsibilities is very important. Practice is very important. And so we, as in every city, there are small and large drills, exercises, whatever term you want to use, to go through contingencies. And those things are very important. They're important in a hospital setting. They're important in the Super Bowl. They're important in cities to really go through the contingencies and to say, all right, this plan says this. There's going to be a new structure here that's not part of that plan. How are we going to get around that? And what's going to happen if these various things happen? It's just putting people through their paces, and it makes the event go better. But you don't want to forget the lessons from the prior one.
Fascinating. Thank you for sharing that. It's always interesting to hear a little bit behind the scenes. I think one of the things that I love about incremental changes is that we learn from other industries, and it would be impossible for me to imagine that we haven't learned something from the NFL experiences and transferred that across. So just a minute or so left. If I could ask you to sort of think about the future of telehealth, telemedicine, where you see this going. This is clearly, it continues to be this sort of resource that we're integrating. How do you see that developing? Do you see a breakdown of who's going to be doing, percentages of telehealth? You talked about some of your providers, 50% doing primary care on that. Where's this all going?
Yeah, so those aren't our providers. There's a industry leader in essentially an HMO, and about 50% of their primary care visits are done by a telemedicine, which is really a very efficient thing for them and efficient thing for their patients, and their patients like it. What I see is a couple of things. One, this will become and is becoming a standard part of medical education. This is change happens, but it sometimes goes slowly. But students and residents are now learning this is a part of what you're going to do, but they need to learn how to do it, and that's going to be an important part of education. And then the industry is still very young from a financial management and business standpoint. We're starting to see a little consolidation in the industry with mergers and acquisitions. Large systems trying to figure out what their system strategy is, and that will evolve over time to something that makes sense for everybody.
Fantastic. Til, thank you very much for joining me. I'm really excited about the telehealth, telemedicine space. I have a vested interest because I'd like to age in my own home. I think it's a key asset in achieving that. And as I said, I practice telehealth with my mother, albeit informally, internationally. As we connected. So very excited and really appreciate you sharing your insights and also the insights from the NFL.
Thank you. Good to be with you.
So thanks for joining me today. Do you have any better ideas, or have you found small incremental changes that have brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick 1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.